I'll start my sharing slides. So my topic has been given that echo assessment of aortic stenosis. So this is the very important valve. This was the almost if you saw after the rheumatic heart disease, the most common degenerative valve. That is the very common, and now with amendment of this TAVI, this valve has become more and more important. Because so what we see in the echo, we see the anatomy as well the etiology of the, because echo will diagnose what is the etiology for this aortic stenosis, severity assessment, what is the LV function, that is very important for the treating the valvular heart disease and associated conditions. So like we have the modality for the 2D, 3D, Doppler, M mode and the TE. So what we see in the 2D echo, we see the mainly valve anatomy, etiology, valve area. That was the more precise with the 3D, the 2D planimetry is not good. And the quantitative LV dimensions, volumes, ejection fraction, mass, LV mass, planimetry, associated chamber enlargement, right heart structure and function. Because if any aortic stenosis or any, as previous speakers also speaks, that tricuspid valve is quite neglected valve and the right heart pressure. Whenever the RB dysfunction is there or the pH is there, the mortality is the more and the morbidity also is the more. And the complications of the valve disease, aortic sinus, aortic anatomy and dimensions, because it's very important to implant the valve the correct side. And then up move to the Doppler segment. That was the most important to assess the severity. That is the LVOT velocity by pulse wave, the velocity across the aortic valve, that is the by continuation wave, Doppler from apex, right parasternal, suprasternal notch, and the subdiaphragmatic views are there taken for the calculate the Vmax, and calculation of the peak instant gradient and the mean gradient, calculation of aortic valve area by continuity equation, and dimensionless index and associated AR, and the M mode we again assess for the LV function, severity assessment, and the T basically when there is a not good view we getting in the TTE, or we want to the planimetry, or we not getting the appropriate gradient, then we go for the T for evaluation of the aortic valve. This was the previous speakers also had shown these slides. So this was the parasternal long axis view where you can see this was the your axis should be you made this aorta LV should be in the horizontal plane. That was the correct. If you are not making correct, you miss that dimensions. You wrongly calculate the annulus size and the sinotubular junction. That is very important for the surgeon to implant what size of the valve is needed. So in this view, you have to see the leaf mobility. You see the thickening of their asymmetric closure line, because this was very important to diagnose the for the bicuspid aortic valve, thickened closure line, and the LVOT dimension, maximal aortic cuff separation in the M mode, and the supravalvular stenosis and subvalvular membrane. So you can in the plaques view you can diagnose this with the valvular, subvalvular, or the supravalvular aortic stenosis. So after this is the parasternal short axis view where you see this the three cups you have to see. Whenever you have to mention on this is the tricuspid or the bicuspid aortic valve, you should see in the always in the systole in the open valve, because many times the bicuspid aortic valve, because of the fusion of the raphe, you see that this triangular shape, but actually this was the bicuspid valve. So whenever you have to comment, you have seen the open valve. So number of the calcification or space area in the planimetry, and this two very important view, bical 5 chamber and the 3 chambers view for assessment of the Doppler and the LV function. And this was the another important view, because the usually bicuspid aortic valve they are associated with the coarctation of the aorta. So you have to see all patients who have the aortic stenosis. You look for the suprasternal view to see that there any dilatation of the ascending aorta. You see for the coarctation. So what you have to diagnose in the echo, you should see the morphology of the valve and etiology. The most common, that is the bicuspid aortic valves, and the degenerative valve, that's the now this becoming the number one, and the rheumatic aortic stenosis that now becoming less common, as in Western countries this was almost rare, but in still in our country this is a common cause of the aortic stenosis. And that's less common, that was the congenital, that's a hyper lipidemia and the oncogenesis. This is the less common causes for the. So whenever you see for the anatomic evaluation, you see the leaflets, mobility, thickness, calcium, and along with that, this was the supravalvular, valvular, or the subvalvular. And T you can do when you are not getting the high quality image suboptimal, then you go for the T. So this was the calcification, this was the tissue structure. You can see there is a nodular calcification mass in the aortic cusp, no commissural fusion, and the free edges of the cusp are not involved, and a slate-shaped systolic orifice. So you have this is the calcified aortic stenosis. You can see the very well. There is a huge calcium is there on this, and the mobility is restricted. Along with you have seen the short axis view. You have this calcified aortic wall, immobility of the cusp resulting in only the slit-like orifice in the systole. So severe calcification, you are sometimes you only unable to see the any orifice because the heavy calcification. So you go for the further means you go for the Doppler. So grading of the calcification, sometimes in this because examiners will ask, there is not very clear cut any grading system is there, but it's given like that. Degree of valve calcification is a predictor for the outcome, the need for the AVR, death, and the heart failure. So mild, only few area of the dense echogenicity with little acoustic shadowing. The moderate, multiple large area of the echo density, and when the severe is there, there is a prominent acoustic shadow, like we saw in the stone when you put the Doppler 2D. There's the acoustic window is there. So one of the this aortic stenosis, that is thickened calcified cusp with pressure mobility. Usually there is the velocity, peak Doppler velocity is less than 2.5. So this was the not in the aortic stenosis, but is the beginning of the aortic stenosis that will further move to the aortic stenosis. So this was the rheumatic. As we know, rheumatic is the typical feature that is the commissural fusion, either by the mitral valve, either for the aortic valve. This is the most diagnostic criteria for the rheumatic. There is the fusion of the commissures as they are present. So this was a triangular systolic orifice and thickening and calcification mostly along the edge of the cusp, and the component involvement of the mitral valve or the other valve. Isolated aortic stenosis in the rheumatic heart disease is quite less common, only less than the 5 to 6% patient having the isolated AS in the RHD, but most of the rheumatic heart disease having the, if aortic valve is involved, maximum patient having the mitral valve involvement also. So this was the how to differentiate. This was the only like this already we have explained. The most diagnostic feature for the rheumatic is the fusion of the commissures. That was the most diagnostic for the rheumatic AS versus the calcific AS. So next part, that was the quite common, it is a bicuspid aortic valve. Actually, the true bicuspid aortic valve is quite less common, less than the 5%, where only you have seen the two cusps. Most of them, because of fusion of the raphe, so almost the 80% of the valve they from the left and right coronary cusps are the fused, and fusion of the right and the non-coronary is the 20%. So two equally bicuspid valve, these are quite rare, and most of this true bicuspid valve they not developing as much aortic stenosis as the other variants. So this was the bicuspid aortic valve in the parasternal short axis view. You can see the two cusp. As I told, if you see in the diastole, you can miss this with the bicuspid or the tricuspid valve. So always you see in the systole. How is the eccentric opening? It is the pismouth opening or the classical triangle shape opening. So whenever you have to going to comment on the bicuspid or the tricuspid valve, you see in the parasternal soft axis view, and in that systole with the proper acquisition of the image. If you are not getting proper image, you can go for that T, where you can get very clear cut picture. It is the actually bicuspid or the tricuspid valve. So in the plaques, you have to see the bicuspid aortic valve. Usually the asymmetrical closure line, systolic doming is the present, diastolic prolapse of the cusp is there, and less specific than the short axis. But whenever you have the plaques, you find the asymmetrical closure line, especially in the M mode, you can suspect this was the bicuspid aortic valve. So in children, valve may be stenotic without the extensive calcification, or may have the functionally normal except for the systolic doming, but need follow. Rarely unicuspid and the tricuspid valve, because they are the very much symptomatic from the time of the birth. Usually unicuspid aortic valve, they are present in the early life, within the infancy. So adult stenosis due to the calcific changes often obscure the number of the cusp. Bicuspid versus tricuspid determined difficult. In such cases, you can go for the T and look for the root, aortic root dilution they are, because the aortic bicuspid aortic valve usually they are associated with the dilution of the aorta. They are the risk for the future risk for the aortic dissections. So this was the then another entity, because in the exams many times they will ask for the supravalvular AS. So this was the usually the because of the membrane. So type 1 is the hourglass type. This is thickened fibrous ring above the aortic wall with less mobility. Type 2 is a thin discrete membrane and usually mobile, may demonstrate doming donation store. And type 3 is that with the diffuse narrowing of the whole ascending aorta you can see. So these were the three types of the supravalvular AS. And next important point, that was the for the basically for the congenital heart disease, we see more patients. This was a subvalvular AS. This should be distinguished from the valvular stenosis based on the site and increased velocities in the. This is very important for the children, because if you have wrongly diagnosed the valvular AS versus to supravalvular AS, because the treatment management is totally different. Because when is the subvalvular AS, only the excision of the membrane or ring is there, and this can be done. So whenever you do, especially for the young people, you should rule out the subvalvular AS is there or not. So this was a thin discrete membrane consisting of the echocardial fold and the fibrous tissue. Type 2 is that is the fibromuscular ridge, and third like the diffuse narrowing of the LVOT, and there is the SS3, the anomalous mitral valve tissue can be seen. So like we all know following, that was the aortic stenosis staging, that was the stage A, B, C, and after that D. So stage A, that was the on the risk, velocity PSAX is less than 2 centimeter. That was the usually they are the patient for the risk, like the bicuspid aortic valve. They have the sclerosis of the aortic valve. They are the under risk. There you can need to follow up the patient, and if there's some like latest guideline has came, if the sclerotic aortic valve is there, you should now you can give the statins for to prevent the further aortic stenosis. So stage B, that is the mild to moderate. Usually the mild AS is 2 to 2.9 millimeter per second the velocity, and the gradient less than the mean gradient less than 20, and the moderate is the less than the 4, and the gradient mean gradient between 20 to 39. So here you can get the, this is the even a gray zone where you get the pseudo severe AS, or the patient with the low ejection fraction and this low flow gradient. So this is the gray zone we later will discuss. And stage 3, that is the asymptomatic severe AS, when the you have having the LV EF ejection fraction more than 50, that is the C1, and the C2 stage there less than dysfunction is there. Velocity more than the 4, mean gradient more than the 40, valve area less than 1, or the index is the 0.6 per meter square, and very severe when the velocity is the more than 5 and the mean gradient more than the 16. So there is the two variant, that is, so one is the normal EF, other with the with LV dysfunction. That is the last, that is stage 3, that is the symptomatic patient. There the D1, that was the patient is the high grade symptomatic patient. Then other, when the mean gradient is less, but EF also less, but DOBUTAMINE stress is positive. This was the classical low flow, low gradient. And third is the, we are getting the gradient less, EF is okay, but the stroke volume is less. So this was the paradoxical low flow, low gradient AS is there. So severity assessment, as echo is the gold standard of the current standard diagnostic criteria for this assessing the aortic stenosis. Right now we very less patient needed for the cardiac catheterization for the routine evaluation. So integral part is the Doppler, 2D, and the clinical presentation. All these three parameters should be in the mind to before labeling the this with the severe AS. So I'm going to discuss only about the Doppler and the 2D Doppler, as the previous speakers already has told about the clinical presentation. So severity assessment, as per the level 1 recommendation for the all, the peak jet velocity, mean transvalvular pressure gradient, and aortic valve area by the continuous integration. This was the class 1 recommendation. And continuous with Doppler ultrasound, multiple acoustic window, the standard view for the apical and the suprasternal and right parasternal view with the most yielding views for the highest velocity. And rarely subcostal or the supraciliator window may be required. So dedicated to all dual crystal continuous wave transducer is recommended. Time scale on the x-axis is the 100 mm per second. Wall filter are set to the high level. Gain is decreased to optimize the identification of the velocity curve. Gray scale is used, most well treated, and the contrast can be also be used. So highest velocity from any window, that is given as the highest gradient. Any deviation from the parallel intercept angle result in the velocity and transition. 5% or less in the intercept then the 15% the parallel. So angle correction should be not used. You should be aligned with the almost 90 degree with the aortic opening, the LVOT. So you can get in the proper. So if you measuring, you can get the highest, you get the highest velocity in the parasternal, right parasternal window, but it is difficult because the what you be using transducer, they are the broad. For especially PIDOF probe is there, you can use. Otherwise, the apical 5-chamber view is the best view where you getting the maximum gradient. So a smooth velocity curve with a dense outer edge is the maximum should be recorded. Fine linear signal at the peak at the curve is not included. Like this, you have seen this is the sum, but it is not giving the correct. So whenever you having the very bright echo shadow, that we should record, and same time you should also calculate the BTI. So whenever the sinus rhythm, at least you measure for the 3 measurements, and when the AF is there, at least you should measure for the 5 cycles. Along with this of that is because when the severe obstruction is there, maximum velocity occurs later in the systole and curve is the more rounded in the shape. When the mild is there, the peak is the early systole and it is a triangular in the shape. And dynamic are the hypertrophic cardiomyopathy where there you can see this initial, there is this was the late peaking will be there. So by seeing the continuous Doppler curve, you can determine it is the severe or the moderate up to mild obstruction, or is the subvalvular, that is the dynamic obstruction, LVOT obstruction, SCM is there or not. So mean transvalvular gradient, the difference in the pressure between the left ventricle and the aorta. So gradient is calculated from the velocity formula. Simplified Bernoulli equation is used because many times examiner will ask which formula you use. So you should remember your little bit of physics. So this was the pressure gradient difference is the 4V square, and the mean gradient is the calculated also from the maximum velocity. The interstitious gradient at any point of time is calculated similar from the interstitious velocity, and average to get the mean gradient. The mean gradient not derived from the mean velocity. So this was the Bernoulli's equation. This was a simplified. I'm not describe much, but you should know this Bernoulli equation. Sometimes the examiner will ask how to going to calculate, because the machines are the set. Once you put the CW, you automatically calculate everything. But sometimes in the examiners will give you the values and tell that you calculate this. So this was the mean transvalvular gradient. That was the peak instantaneous gradient. That was the maximum. So mean gradient, mean of the difference in terms of velocity should be recorded. The sources of the error, where you get the wrongly, if you have the mal aligned, as we already I explained, even though in the minor degree of the angle deviation, you have get the lower velocity. So you should be alignment should be very proper. You should practice very well. So otherwise you will miss the severe AS, because this was the for the all purposes. This was the only criteria where we assess the severity of the aortic stenosis. Sometimes you have to pick the MR jet. That was the also be the, you bring the very high gradient. If you have picked the MR, any underestimation of velocity result for even the greater underestimation in the gradient with the squared relationship between the velocity and the pressure difference. Neglect of the elevated proximal velocities. So like this with the wow you get so MR versus the AR, you get the wider jet. If you have picked wrongly for the MR, you have to get the wider jet. The AS will the jet will the quite narrow, and the more symmetrical superimposed electric suggest the LV jet. So whenever you have seen, you should the color Doppler should be, is there MR is there or not. You should exclude the MR, otherwise you wrongly diagnose. Another very important question asked in the exams, that Doppler echo maximum interstitious pressure difference on the wall. So Echo Doppler pressure tracing difference between the peak and the left ventricle and this. So you practice this graph because many times examiner will ask how to in the CATH study they will give this how much the difference between the peak to peak and the maximal entrance gradient is there. Another important aspect for the aortic stenosis, there is the pressure recovery. Potential energy converted into kinetic energy across the narrowed wall, resulting in the high velocity and the drop in the pressure. So distal to the orifice, the flow decelerates and some kind of the kinetic energy dissipate at the heat, depends upon the turbulence. Remaining will the reconverted into the potential energy with the corresponding increase in the pressure, so-called the pressure recovery. Pressure recovery is the greatest in the stenosis with gradual distal widening. So aortic stenosis with the abrupt widening from the small aorta to large aorta unfavor the geometry for the pressure recovery. So pressure recovery, how do you correct the pressure recovery? So the ratio between the effective orifice area and the descending aorta area determine the magnitude of the pressure recovery. The net pressure gradient measured gradient minus the pressure will depend on the hemodynamic significance. So most adult magnitude to be ignored unless the aortic width is less than 3. So whenever the you find the wide aorta, you can calculate for the pressure recovery to correct what is the actual gradient. So smaller aortas eco-evolution overestimates the pressure gradients. So this was the correlation between the catheter based versus Doppler. They are very well matched. So that's why now the Doppler study has the more, we are not recommending much for the CATH study to diagnose the severity of the aortic stenosis. So this was the very important aspect of the aortic stenosis when how to calculate the valve area, because the planimetry is a not good method as the Kumar has told. For mitral stenosis, the planimetry is the gold standard, but for the aortic stenosis, the planimetry is not good method to calculate. So this was the you should acquire the LVOT diameter along with the VTI. You should how to measure the VTI. It is the pulse wave. You should from the apical you gradually slowly come down, and where you get the very good cap, you should record as the VTI. And then again the continuous wave for the VTI 2. So you should calculate like that's what is the effective area, that's the cross-sectional area you can calculate by the LVOT diameter and VTI of the LVOT, and then this was the VTI for the aortic valve. So how to measure the LVOT? You should be always measuring in the zoomed way because when calcification is there, you can wrongly measure the LVOT diameter. So whenever you should acquire very good, you should adjust the gain and everything so endocardial border should be reflected very well. So zoomed inner to inner, the septal endocardial to the anterior mitral leaflet, parallel to the aortic wall, annulus at the annulus are within the 0.3 to 1 centimeter of the valve orifice area, and the average 3 in sinus rhythm and the 5 in the irregular is the AF is there. So as you LVO2 measurement to done. So what difficulty there be many times you have seen calcium is so much calcium is there, it is up to the mitral leaflet. So because once the calcium is there, this will not to LVOT. So you should measure in some other views and the sigmoid syndrome of the LVOT, because the many times the hypertrophy of the septum is too so it is become the sigmoid space. This will also getting the false narrow LVOT. So outflow tract not imaged clearly by the in the mid systole or end systole, and the practical approach to measure to frame that L at largest diameter. Whenever you get the largest diameter, you should consider as the real LVOT diameter. The LVOT is not perfectly cylindrical. If TT is not good, you can go again for the T. T is recommended whenever you are getting in the imaging in the TTE. So velocity adjustment, apical 4 chamber or the 3 chambers is the best view, and the pulse wave sample volume is the projection just proximal to the wall, ideally at the level of the LVOT dimension. So you can see this is the, you can keep the pulse wave just where the wall has been opening. So where you have measured the LVOT same present, you can, but LVOT should be measured in the plaques view. It is in the 4 apical 5 chamber view. So And continuous wave is difficult because, as we know, this was the pulse wave is the point. It is measuring all the wave. So velocity measurement, you should have done the sampling like we have discussed earlier. So optimally positioned smooth velocity curve, well defined peak is obtained. That was the for VTI only closing click thing. So severe AS may have to move the sample volume more than the towards apex, measuring the LV diameter at the same level. So limitation, what is the major limitation? As we know, this was the intra and the inter-observation variabilities are there. There is a much 5 to 8% variability in the measuring. So if you have assumed that's circular, maybe this was the cylindrical or the elliptical. So multi-detector CD or the 3D echo is the much better rather than the 2D echo. When subaortic flow velocity or the subnormal, the stroke volume calculation at that point is not accurate. Sample volume replaced near to the septum or the anterior mitral leaflet. Observe change in the valve area and change flow to rate. So normal LV function effects of the flow is the minimum, but when the significant dysfunction is there, it will not give the correct. So this was the summary as we have earlier discussed. This was the peak more than the 4. That was the severe. If this was the stronger predictor for the clinical outcome. When the mean gradient, this was the EG. This was the very easy to two criteria. Because EG, there is a less variability, high specificity, and a strong predictor for the outcome, and compared to the invasive CATH studies. So only limitation, if you are not getting the parallel alignment, you having the overestimate LV energy loss at the rotor, like the pressure recovery, underestimate the presence of the systemic hypertension, and low flow cases. So valve area by continuity equation, it is quite difficult. So relatively flow independent. So clinical severity, it is reflect as clinical severity can be used in almost all patients. But as we have discussed, there is a lot of limitations for these continuity equations. So what alternative measurements we can do? This was the label 2 recommendation, reasonable when the additional information needed in the selected. So simplified continuity equation, velocity ratio, also called as the dimensionless index, the VTI ratio, and the aortic valve planimetry. So this was the simplified continuity equation. So you measure this with a native aortic valve stenosis shape and similar in the aortic valve and LVOT. So you can calculate aortic valve area. This method is less accepted because the results are more variable than the VTI in the equation. Also requires the calculating stroke volume. So this was the velocity ratio. This was the little simpler. You just measure the LVOT maximum gradient and the aortic. So you measure the ratio along with the velocity ratio. We can also use the VTI ratio, the LVOT VTI and the VTI of the AV. The severe stenosis suggested if the VR is the less than 0.25 or less, corresponding to the valve area of the 25% of the normal. It is little bit flow independent criteria, so it also with a very good correlation with for the only for the severe aortic stenosis, not for the mild to moderate. So planimetry, as we have told already, we have discussed the calculation anatomic orifice area. Accepted alternative when the Doppler estimate flow is unreliable, inaccurate if valve calcification causes the shadow or the reverberation, and T has better correlation with the invasive or the continuity equation or the multi-detector CT, and T is preferred for the to assess for the planimetry for the aortic valve. So this for the T, you can measure the mid-esophageal, the short axis view, you can measure the valve area. So this was the experimental. This is not recommended like the stroke work loss. Sometimes examiners will ask energy loss. How do you calculate valvular atrial impedance, aortic valve resistance? So multiple in the long back, these all criteria are used, but after the coming of the Doppler, all these criteria are less used because they are not very consistent, difficult to calculate, and much variability is there. So this was the grading less than 2.5. That's the labeled as the aortic stenosis. mild to moderate. This was we in first slide, previous slides we have discussed more than 4 is the severe, gradient more than the mean gradient more than the 40 is the severe, valve area more than the 1 is severe, less than 1, and the index area 0.6 centimeter square is the, and the velocity ratio less than the 0.25, that was the severe aortic stenosis. So difficulty in the special situation, ideally this would be correspondence between the different measurement. All measurements should be made when the patient has the normal BP. As we have discussed, because the Doppler study has been, because the pressure gradient, if you the high BP are the very, so this will reflect wrong values. So patient should be in the normal blood pressure, integrated with the other imaging and the clinical judgment before the giving the final report. So this was the difficult at the situation, valve area more than 1, but peak velocity less than 4 and mean gradient less than, but strong clinical suspicion. So you should be, such patient you should be indexed, because many times they are short stage of patient. Yeah. So whenever you have found this very short stature or the very tall guy, you should index the valve area. The indexes should be used, and you can consider for the low flow state. So whenever you're getting the valve area more than 1, but velocity and gradient is high, so maybe there is a concomitant AR is there or other central lesion. So reversible causes like the fever, anemia, hyperthyroidism, AV fistula dialysis may be excluded. When we are getting the velocity and gradient very high, but you have done the continuity equation and you're getting the valve area more, so you should rule out this other medical condition. Another important aspect is valve area is less, but peak velocity and gradient is low. So exclude first your measurements errors, small stretcher and low flow, low gradient, because this was the most important aspect. Whenever you get the AS case in the exam, they will ask for the low flow, low gradient. So low flow, low gradient AS with reduced ejection fraction, that was the classical low flow, low gradient AS. Orifice area less than 1, gradient less than the 40, stroke volume index that was in less than 35, and EF less than the 50%. So true AS are the moderate AS with the low AF, that was the pseudo severe AS. So how to differentiate? The most recommended way to differentiate it, dobutamine stress test. So how to measure this? So the contractile response, change in the ejection fraction, and the increase in the stroke volume, that was the flow reserve, and thus change in the velocity, mean gradient, and the valve area as the flow increases. So it is help in the identifying severe versus the pseudo severe AS, because if once the severe AS is there, you need to go for the either the valve replacement or the TAVI. And severe AS causing the LV systolic dysfunction is the moderate AS with another cause for the LV dysfunction. So this was the standard protocol. You use the 2.25 microgram per kg per minute and incremental dose for the up to go to a maximum dose of 20 microgram per kg per minute. So every stage should be monitored for the 3 to 5 minutes, and infusion is stopped when the dobutamine reached the maximum dose, that is 20 microgram per kg per minute, and the positive result is obtained. Either heart rate is increased 10 to 20 beats per minute from the baseline or exceed more than 100. Symptoms, blood pressure falls or significant arrhythmia, then also you should stop the infusion. The positive result and increase the effective aortic area to a final valve area more than 1 suggests the stenosis is not severe. Severe stenosis is suggested by the aortic jet velocity more than 4, mean gradient 30 to 40. 30 to 40 private, that valve area does not exceed more than the 1 at any flow rate. And the absence of the contractile reserve, that is the failure to increase the stroke volume, is a predictor for the high surgical mortality and poor outcome. And although valve replacement may improve the LV function, outcome in this subgroup also. So LVOT baseline measurement as standard we have discussing already discussed. So LVOT baseline measurement is to do aortic and velocity recorded in the each state. EF should be measured at least twice at the baseline in the peak, and patient having the low ejection fraction but the high gradient of velocity does not have the impaired equilibrium, still should be not indicated. So this was the this image is some missing. So this was the true yes, even though you have given the flow is increased but the valve area is fixed, that was true. This image is not clear, but there when the flow is stroke volume is increased, the orifice also is increased and gradient has been falling. So this was the no significant change in the when the true severe AS is the no significant change, but mean gradient you can see this was increased from 30 to the 56. That was the low classical low flow low gradient severe AS. When the pseudo AS is there, you can see there is no change in the orifice area, but gradient remains fairly constant. So low flow reserve. So increase in the stroke volume less than 20 with low EF patient, DSC failed to demonstrate response. Alternative option, you projected ABA, either you can go for the CT for the calcium scoring. Now recommendation has given for the multi-detector CT to calcium scoring to assess the severity in such cases. So projected aortic valve area and increase during the stage of the DSC, projected flow of the 250 ml per minutes, average flow rate achieved in the patient with the severe AS and at normal function. Minimum of 15% increase in stroke volume needed to calculate at the projected area, and this also be not seen in the 10 to 20% cases. So this was the classical low flow low gradient AS, dopamine stress. Your stroke volume has been increased. That was the flow is reserve, but when this is not there, you should be go for the further CT scan. You can score for the calcium scoring. If more than the 200 for the females, more than 200 for the male, it is a true severe AS. You can consider for the surgical or the transcatheter valve replacement. And this was the like classical. You have get the true severe AS or the pseudo. You should only for the heart failure therapy. Patient will improve, but do patient who having not getting the stroke volume, you should recommend for the CT to calculation for the calcium external score for the further management. So low flow, low gradient with presumed EF, that's the paradoxal AS, 5 to 10% of the AS, hypertrophied small ventricle with low and diastolic volume, elderly patient having long-standing systolic hypertension, reduced valvular transvalvular flow despite normal EF. Always rule out the mechanical errors before diagnosing low flow, low gradient AS with the pressure EF. Severe AS highly unlikely when the velocity is the less than 3 and the mean gradient is less than 20. So very difficult to diagnose. DSC is not very helpful in such cases. So you further increase the flow rate. First, rule out the systemic hypertension, technical error, and confirm whether the AS is the moderate only. If clinically is the moderate, you can also reconsider. And only definitely condition for the severe AS when the high calcium score on the multi-detector CT. So this was the clinical criteria. Physical examination consistent with the severe AS, typical symptoms, and without any other explanation. Old patient more than 70 years, LVH is there, and you have the reduced, if you have done the strain, you longitudinal function without the other explanation. Mean gradient less than the 40, valve area is 0.8. Low flow is there, stroke volume index is the less than 35 ml per meter square, confirmed by the other techniques. So such cases you go for the multi-slice CT scan for the calcium scoring. If more than the 200, that is the severe AS is there, that's where you go for the intervention. If more than the 3, likely. If less than the 1600, you should rule out it with the severe AS, and in females less than the 800. So this was the valvular approach. What you do, if the high gradient, assess the, you have suspicion of the aortic stenosis, you assess the velocity gradient, you have found a low flow gradient, you assess again for the further DSC and other method you can go. If you have found a high flow status excluded, yes, then the high severe flow is there. If no, then definitely the high flow is reversible. If not reversible, this will be severe AS, reversible, reassess at the restored normal flow condition. So this was the next step. You have found that the stroke volume less, assess the LVEF. If less than the 50%, do dopamine stress. It is the flow reserve or unreserved. And if the flow is reserved, it's a pseudo severe. If the flow is true severe, and if you are getting more than the 50% of the EF integrated approach, you again go for the CT scoring to detect this was the really true severe AS is there or not. So in the last, because the MOD we are not much considering, because there is now only this separation of the maximal aortic cuff separation. That was the, if you getting the separation more, it is the more than the 2 centimeter of the aortic valve area, is more than the 15. If you're getting the suppression more than 1.5 centimeter, it is the 100% predictive value. It is not any severe AS. But you less than the 8, it is definitely severe, but it's the gray zone between the 8 to 12. So whenever you're getting the suppression more than 1.5, you can rule out this is the not severe. But for further moderate to severe assessment, you need to the other modality rather than the M mode. So because we see the lot of patients with the hypertension associated with the aortic stenosis, because this is now the old age disease, degenerative disease. So most of the almost 40% people having the hypertension. So aortic stenosis can be concealed the hypertension, especially when there is a low flow stage, and the hypertension can mask aortic stenosis severity primarily by affecting the flow and the gradient, because the less valve area is measurement. So whenever you have the patient, you should control the blood pressure before the echocardiography, giving the severe AS diagnosis. And the global AV load depend upon the both AS severity and the valve after the load, which is not usually in the severity. So this was the sometimes all this criteria are not much used nowadays. So sometimes this valvular atrial impedance will ask by the examiners. It is the energy of the amount of the energy in the millimeter of mercury needed to pump 1 ml of blood by the left ventricle against the load imposed both by the valve and the peripheral vascular resistance. So global systolic load to the LV and thus assess the hemodynamic consistency. You can manage systolic blood pressure, the pressure difference net, and the stroke volume index. If this score valvular impedance is the more than the 4.5 millimeter of mercury per ml per meter squared, it signifies the severe disease. So in between this, if you have asymptomatic moderate to severe AS, if more than the 5, predict reduced event-free survival, 2.8-fold increase in the risk of the death. Drawbacks does not identify the relative contribution of the valve, peripheral vascular resistance, necessary to guide the management, AVR versus the VV control. So as we know, this aortic stenosis 80% has associated the AR, the component AR is there. So because when the AR is usually mild to moderate, it doesn't affect the severity. But whenever the high severe MR is there, it will always show this way there, because flow rate, maximal velocity, and mean gradient will be higher expected in the valve area. So quantification of the severity of both lesions should be reported. So associated mitral valve disease, always look for the, especially for the rheumatic case, is the mitral. Whenever the severe MR, again the aortic flow may be low, resulting in the low gradient, even the severe AS is there. Calculation for the aortic valve area is remain accurate if flow is calculated by LVOT, not by the volumetry. So high velocity MR get mistaken for the AS. So you always, we previously discussed, mitral stenosis, low cardiac output may result in the low flow and low gradient. So whenever you have then seen the aortic stenosis, you should look for the mitral valve, associated mitral stenosis or the mitral registration. Next important part, the associated, because the ascending aorta is very, very important to look for the AS patient, because you have in the dilution, dissection, and the aneurysm can be formed in the AS patient, especially by bicuspid aortic valve or the patient having the marfan or other. So diameter at the sinus at the sinotubular junction and ascending aorta should be measured. Dilution of the aortic valve associated with the bicuspid aortic disease and the aortic size may impact the timing and the intervention. So prognostic, after this, with the prognostic indicator for the asymptomatic severe, the peak velocity, as the higher peak velocity, very severe. This was they have the risk for the sudden death, heart failure, and syncope. So severity of the valve calcification, heavily calcified valve having the poor prognosis, ejection fraction, hemodynamic progression, and the increased gradient with exercise, excessive LVH, and the abnormal, this especially for the strain, if you're doing the strain imaging, abnormal longitudinal LV function, and the pulmonary hypertension. It will also be neglected, because if once the pulmonary hypertension is developed with the AS, the prognosis will be poorer than the patient who having not pulmonary hypertension. So when the asymptomatic patient having the peak velocity more than 5.5, they have the worst prognosis, combination of the severe calcification and rapid deterioration more than the 0.3 meter per second per year degradation is there. Otherwise, mean gradient is increasing more than the 20 with the exercise. This was the candidate who recommended for the, despite the asymptomatic status, recommended for the AVR or the other method to valve replacement. So stress cardiography in the true asymptomatic patient to assess really they need the intervention or not. If this was the mean gradient increase more than the 20% or the EF drop, this was the patient recommended for the ABR. If no, you can follow every 6 to 6 months for the severe AS and every 1 to 2 years in the moderate AS. So stroke volume work loss. This also be sometimes is asked. The stroke volume wasted in the ejecting through the aorta and they keep the valve open. So this will be calculated with the pressure mean gradient plus systolic PVM and multiplied by 100. Cutoff value is the more than the 25 discriminate between the patient experience a good and a poorer outcome. So this was the last my presentation. Last I will summarize only the most important thing when you going for the assess the AS. The simplest and the best criteria is the peak velocity in the continuous wave and the mean gradient, because these two criteria is the very simple to assess, and most of the practical purchase we are doing this, and third with the continuity equation. So whenever you having going for the do the echo before the diagnosing, you should check the blood pressure is normal or not, rule out the other hyperdynamic circulatory stresses. Peak velocity more than the 4 is almost suggestive of the severe aortic stenosis, should be obtained in the multiple planes, which is the higher should be considered the maximum. Mean gradient also be the more than 40 is the constituted in the severe AS. The mean gradient calculated by the averaging the instantaneous gradient over the ejection period cannot be calculated from the mean velocity. A common source error that with the malalignment, so you should have the very good window before the leveling the severe AS. So this already we have less than the 1 is the considered with the severe AS. Continuation equation is well validated. LVOT diameter should be measured in the PSAX view. LVOT velocity is recorded in the pulse width Doppler, the apical 4-chamber or the 3-chamber view, and you should have where the you get the smooth curve that we consider the VTI, and other major limitation the continuation is when the north circular LVOT is not there. So follow aortic jet velocity is the same window when you are giving the maximum velocity. Otherwise, you following the giving report, you should mention it is measured in the 4-chamber view, 5-chamber view, or the 3-chamber view. And the EF changes look for the individual component. LVOT size really change over the times in the adults. So this was the low flow, low gradient. So we already have whenever you get the patient low flow, low gradient, you should go for the DOBUTAMINE stress test between the pseudo and the real severe AS. And if you are not getting still the correct, you should send for the CT scan, multi-detector CT for the calcium scoring. So this was the last. In last, I think no much person is there to interact for the MCQ. So gradient in the best view. So as we already discussed, apical 5-chamber and the suprasternal view, that is the best view to assess your gradients. So another very common question asked in examination continuation equation is example of the law of conservation of mass, momentum, energy, Pascal's law, the Conoda effect. So answer is that it is the law of conservation of the mass. So this part only to you read how to calculate. Many times the examiner will give you values and tell us calculate the valve area. And this was the again because we have discussed the stroke volume, how to calculate the stroke volume. So answer is there. You should stroke volume should be measured from the LVOT cross sectional area multiplied by the VTI. Whenever you want to Doppler based the echocardiography, you calculate the stroke volume with the heart rate. This will give the cardiac output status. So this was the another important question asked in the exam. In patient with the mixed aortic valve, aortic valve area by the Gorlin equation and using peak output is likely to be less, more, or the same. Another again based the mixed valve area by Gorlin using angiographic cardiac output is less, more, or same. So answer is there. Whenever the mixed valve is there, if you measure by the peak method less than the transvalvular, the peak cardiac out plus pedestrian valve has the calculation by the AVI by Gorlin will underestimate the aortic valve area compared to guys continuation equation. So Gorlin equation will overestimate the aortic stenosis severity, and whenever the angiographic and Doppler cardiac almost equal. This was the only graph to continuous wave signal from the apical view. This suggestive of mild, moderate, MR, or prosthetic valve obstruction. So only clue is there. You can see these two bright marking is there, opening and the closing of the leaflet. So this was the prosthetic valve stenosis is there, obstruction. You should, whenever you label for the prosthetic valve obstruction or the stenosis, you should know the wall. You should know the normal gradient across the wall. Then only you label for the this was the stenotic or not. So this was the last prize. Thank you, sir. And
yeah.
I think little bit longer. So
no, it's fine. You have covered everything. And now our intention is, are you able to hear?
Yes, sir.
Our intention is to conduct a very good educational program, and we wanted to record these lectures, as well as we are making a PDF files also. Whatever sir. You have presented.
Yes, sir. I will send.
I will ask Mani to take from you, and we'll make a book. We'll make everything like a valvular update. So yes. We'll prepare PDFs, because this is very useful to the postgraduates and for us also for revision sake. So it's very difficult to go through all the details in one book. So because you people have put in the best effort to compile everything. So I think we can collect all these papers and we will bring it into the form of book. So that will be useful forever for all the students. So that like a exam point of view, I think I really appreciate you for extensively covering, but you have covered each and every aspect of the aortic valve stenosis, echocardiographic. It's worth keeping that presentation, frankly. I'm saying, but you have covered even the latest aspects. And I told you repeatedly, I appreciate you very much for academic skills. You always maintain that momentum. You have shown that updated version also. That is very, very important for any cardiologist, because we have to keep pace with what is going on, even in the latest like ESCR, ACC. These are all very, very important. Dr. Shailendra Singh is there. Dr. Vijay Kumar Reddy.
I think sir is there.
Dr. Shailendra. Nearly 150
exhaustively covered. Everything he has covered in aortic stenosis.
Yeah. Very good. Actually, sir, excellent. Because when I have passed, that time the CT scoring is not included in the severity.
Yes.
But just I also revised. The CT scoring also came for to assess the severe AS.
Yes.
Such cases.
Yeah.
Because only we do coronary calcium score. So
Lokesh, nearly 150 attendees are there. But we have not allowed the interaction because it's getting delayed.
Yeah.
Interacting, that reason actually I allocated 20 minutes for every speaker.
Yeah.
But every speaker took 35 to 40 minutes. There is no scope for discussion. Yeah. So now we started sharp at 9 o'clock without any interruption. Now we ended at 2 o'clock. So there is no scope.
1 hour delay.
Yeah, 1 hour delay.
Extra.
That also there is no discussion, no questions. Suppose if I am allowing the interaction, it is impossible to cover all those things within time. So that's the reason I told every speaker to display the questions, and when we are making a PDF and when we are sending them, that those answers also will give them, and will give the rationale also. That is our intention. But Dr. Vijay Kumar is there?
Yeah.
Sir, I think both of you can comment about our speakers. Then I will say a final few words about our. Actually, they are all very gems, I can say, because yesterday I sat almost for 3 hours. I did not get up even for 5 minutes. Today morning 9 to 2 o'clock, totally glued to chair. That is all because of their talent, because they have presented very high quality presentations. What do you say, sir, both of you?
Yeah. Dr. Lokesh, as usual, is excellent and brilliant. He has brought out so many new points. Another things he mentioned that the disparity between the CATH derived these gradients and echo gradients is is pressure recovery. So pressure recovery is very important aspect. The same. And Lokesh, as usual, is a very excellent speaker and good analyst. All the speakers, they brought out the best of them, and it is. I sincerely hope that it is very much useful to the budding cardiologists and students.
Thank you, sir.
Shailendra sir, anything you want to add?
Yeah. I think it was excellent. I think all the speakers did very good job. Lokesh did especially very good in telling every point about aortic stenosis. I think
yeah. And covered all the latest aspects.
Yeah.
So today, all of you made my day. Really, I thought of giving a very good updated valvular information mainly. Many times, even as a practitioners, we focus more on the coronary interventions, everything. So we thought this will be a revision to us also. I learned many things, and many things, frankly, you have given the updated version. That is truly, I am very thankful to each and everyone. And I appreciate everyone's effort. My special thanks to all the speakers, Dr. Shravan, Dr. Naveen, Dr. Guru Chaitanya, Dr. Dhanunjay, Dr. Rajaram. Yesterday they spoke, and today Dr. Vamshi, Dr. Pragati, Dr. Tushar, Dr. Vinod, Dr. Bax, and Dr. Kaustu, Dr. Lokesh, and Rakender. So despite their busy schedule, they contributed and they paid enough attention to make it very successful. I think your contribution is invaluable. I think this will go in a long way, and definitely this will be useful to all the postgraduate students. I think this information we'll try to bring into the form of book or PDF, and we'll circulate it to all medical college students, and even for future students also for a few years. This will become like a reference for valvular, because you people have put in a best efforts to cover all the aspects, mainly from exam point of view, and each one has focused to all the highlighted also the exam points. That is very, very important. And with this note, Shailendra Singh, I think you have not spoken the final words. Dr. Shailendra Singh, sir.
I think it's a very good program, very educative program, and very useful for students and postgraduates, and very useful for practicing cardiologists also, because to know each and every point is very important, because you come across patients who present neither this way nor that way, and therefore all this knowledge and data will help you in trying to decide what is required for that patient. So that way it is very, very useful clinical practice guidelines, and therefore this is such exhaustively covered. I think it's very important to get a book out of it, and then that will be very useful. Yes.
I request all the speakers, you might have shown some of the slides with figures. There you are narrated, but there if you write underneath that, if you write a description, and it will be expressed very nicely in the book. Please see that you are adding the text at the bottom of the figure. That is also very, very important. And I will ask Mani to coordinate to bring it into the form of book. And this program has been sponsored by Sun Pharma. Special thanks to Sai Baba and his team, because they have worked day and hard. They were communicating with each and everyone and designing even teasers, everything. They have come forward to support when I requested them, because we wanted to educate mainly postgraduates, because we have many talented young cardiologists. They are fresh with the subject and everything. I thought we'll utilize this one to make it a good academic program. I think we have achieved what we wanted to do it. I think it's a long way to go, and in the future also I will be coming up with like a myocardial diseases update, like a cardiomyopathy, like a hypertrophic cardiomyopathy, like a dilated cardiomyopathy, restrictive cardiomyopathy, and that is also exam oriented. I think with this note, I thank each and everyone. My special thanks to all my speakers, and special thanks to Dr. Shailendra Singh and Dr. Vijay Kumar Reddy. And frankly, they have been sitting all the time, and they were encouraging, and they are involved in active participation, and they were also suggesting some of their ideas. I'm thankful to each and everyone. With this note, I'm closing this session. I wish you all a very great success, and from the bottom of the heart, I respect you a lot, all of you. I'm very, very amazed and happy for your talent. Thank you. Thank you, one and all.
Thank you, sir.
Happy sir.
Lokesh, really, I miss you.
Sir, today I have refreshed. Everybody, Kaustubh is there, and Tushar is there. Pragati also we have seen,
because
all three sirs are there.
Physically you left, you are all in our memory. Then I thought in Zoom, why don't we involve all our people? There are so many talented people are there. Then okay, let us use them so that at least we can see each other, we can interact. With that intention only, I started this one. Okay?
Okay, sir.
Right, bye.
Okay, thanks, sir.
Right, Kaustubh?
Yes,
Tushar?
You, sir. Bye, sir.
Bye.
Bye.
Okay.